Welcome, everybody. This is Rush University Medical Center Division of Nephrology Renal Biopsy Conference for October 14th, 2021. Today's CME activity code is 483778. I'd like to welcome everybody. We have two visiting residents today interviewing for fellowship, and we're glad to have you. As usual, we'll present a case and go over it in our typical fashion. The case is de-identified. And we have nothing to disclose. These are being recorded and will be available on YouTube shortly. And we do have a chat board, so if you have any questions, just put it in there and we'll try to address it as we go through the conference, either during or live or later. We invite everybody to put their questions in. Today is Boards Day, and so if you're on the Zoom today, you're not taking your nephrology boards, or you're done pretty quickly. So I can't wish you good luck, but we should all be thinking of our colleagues who are out taking the boards today and our ex-fellows and everything else. So we have a great case today. It'll be a lot of fun. I look forward to presenting my case. Dr. Chintav is going to be discussing it, and I think we can put it up and Chintav Shah, you're there? You want to unmute yourself?
Go ahead, Chintav. You should be able to unmute yourself now.
You guys hear me?
Yep.
Yep. We'll put the case up and you can present it.
All right. So we have a 65-year-old non-COVID vaccinated Caucasian female with past medical history of left parotid cancer, status post-parodectomy, neck dissection, and radiation in 2002, right breast ductal carcinoma in situ, status post-lumpectomy and radiation 9 months ago with no chemotherapy, hypertension, hyperlipidemia, who presented to an outside hospital with complaints of dyspnea and exertion and lower extremity edema for past few weeks. Her blood pressure on arrival was 220 over 110. Admission labs showed a BUN of 82 with creatinine of 1.5. The only other value we had in the medical report was from 6 years prior, where her creatinine was 0.5. She had an albumin of 2.5 grams per deciliter. She was also anemic with hemoglobin of 6.7, thrombocytopenic with platelets of 76,000, and had an elevated LDH at 500. And normal is less than 225, and a low haptoglobin at less than 20. Normal is 30 to 100. The peripheral blood smear showed schistocytes. Her UA showed greater than 300 protein, large blood greater than 100 RBCs, 0 to 5 WBCs, no hyaline cast, and 0 to 5 granular cast. Her urine 24-hour protein was 2191 milligrams per 24 hours. She also had a temperature of 102. Blood cultures drawn after admission, 2 out of 2 grew MRSA, and she was started on vancomycin. She had an echocardiogram, both transthoracic and transesophageal, that didn't show any vegetation. Her culture cleared rapidly, and she was continued on vancomycin. During this hospitalization, her serum creatinine increased from 1.9 on admission to peak of 5.6 in 3 days with decreasing urine output. She was started on hemodialysis, and then she denied any NSAIDs use, rash, arthralgia, hemoptysis, shortness of breath, or weight loss. Her past medical history, she has hypertension, hyperlipidemia, hypothyroidism, COPD, and the parotid and breast cancer. Surgical history, she's got history of parotidectomy 20 years ago, a lumpectomy. She has a history of mandible graft. Social history, she is a current smoker, occasional alcohol use, no illicit drug use or over-the-counter herbal medication. Family history, there's no family history of kidney or autoimmune disease in first-degree relatives. Father had liver cancer. Review of systems, positive for fatigue, poor appetite, left-sided hearing loss, bilateral lower extremity pain, and abdominal distension. She had no known drug allergies. Meds-wise, she was on allopurinol, pantoprazole, lisinopril, atorvastatin, levothyroxine, anastrozole, carvedilol, and hydralazine. On physical exam, her temperature was 97, blood pressure was 145/70. Pulse was 80 with respiratory rate of 18. Her height was 148 centimeter and she weighed 169 pounds with a BMI of 31.79. She was 98% saturating on room air. She was alert and oriented, resting comfortably, no distress, no lymphadenopathy. Lungs were clear, no increased work of breathing, good air exchange. Cardiovascular normal rate and rhythm, no murmur or rub. Abdomen was soft, normal bowel sounds, distended but non-tender. Musculoskeletal, no joint synovitis. Neurological, no focal deficit. Skin, there was no rash. Extremities, there was 2+ edema present bilaterally. On labs, we have a CMP that showed sodium of 136, potassium 4.3, chloride 99 with bicarb of 16, BUN of 110, creatinine of 5.7, glucose 88, total protein 5.5 and with albumin of 1.9, calcium was 8.2, T-Billy, ALK-Phos, AST, ALT were all normal. CBC, she had a white count of 11.9 with hemoglobin of 6.7. Her MCV was 86.1 and platelets was 76. She had a C3 that was 39 and C4, which was 3.1, very low. CH50 was less than 12.5. A normal is 38 to 89. She also had a positive ANA 1:40 with nucleolar pattern. SSA, SSB, PNCA, MPO, dsDNA, anti-RMP, and Smith all were negative. Her CNCA was elevated at 1:320 with a PR3 of 4.6. The normal is 0 to 3.5. She also had anti-glomerular basement membrane antibodies that were negative. Her ADAM TS13 was greater than 100. Cryoglobulins were pending. Antihistone antibodies as well as antiphospholipid antibodies were pending. COVID, HIV, Hep B, surface antigen all were negative. However, she had a Hep C antibody that was positive, but Hep C PCR was negative. UA showed specific gravity of 1.025. Yellow, pH was 5.5 with no glucose, greater than 300 protein. Large blood, 50 to 100 RBCs, 15 to 25 WBCs, negative leukoesterase, no squames, no hyaline or granular cast. Her 24-hour urine protein was 2,191. Chest X-ray showed no acute process. Renal ultrasound was done that showed both kidneys were normal in size and echogenicity. Right was 12.9 centimeter, left was 12.7 centimeter in length. No focal renal lesions, stones or perinephric fluid collection or hydronephrosis was seen. Percutaneous renal biopsy was performed.
Thank you, Chintav. Any questions for Dr. Shah?
Dr. Shah, I know that you said there was no drug history, but did you guys get a urine drug screen?
No, we did not.
Okay.
Bill, are you talking about a levamisole?
Yeah.
Or just in general?
No, I was, yeah, specifically, I mean, we can get a urine levamisole, but I was really, looking for levamisole, possibly the urine cocaine would be positive.
Have you seen a levamisole actually come back? I know we've tried to order them. I don't know that I've ever seen one come back.
Yes, I have. It takes a week later, so it doesn't ever change anything. But if you get the urine cocaine positive, then the other thing is I think it's rapidly metabolized. So I think you have about 12 hours from last use to get it into the urine.
Wow, that's interesting and very useful information because it may be 48 hours before you think of ordering it.
Yeah, you got to get it within 12 hours and it comes back within 7 days. So that's why we never see it.
We have a poll, but we're going to save the poll for after the discussion. I'd like Dr. Baxi, could you kind of walk us through your thoughts about this case? There's a lot of stuff going on here.
Yeah, actually, there is. Talk about a lot of different things, but essentially, you kind of look at what she presents. She comes in with, AKI. We don't have a prior, recent baseline, but, she was normal at least 6 years ago. She comes in severely hypertensive, low albumin, and, evidence of, hemolysis with, schistocytes, low hapto, high LDH, and you're already thinking TMA, but as you go down, then she has a lot of proteinuria. This is in the setting of, reduced urine output, but she still had a 24-hour urine protein of 2 grams. She has some granular cash, sure, because she has some ATM, but that's not going to explain the whole picture. So then, her creatinine starts to rise in the hospital, which, typically for me signifies, something that's happened during the hospitalization, be it meds, hemodynamic changes. So, sure, that could be ATN, but then when you look at the urine, she has an active urine. She has a ton of blood, a ton of RBCs, even though we don't see CAS, but you have to treat that as an active urine sediment. And with increasing, creatinine, it's hard not to, you really have to, consider RPGN and you look at the complements and some of the other things. So at this point, with the urine being that active, RPGN becomes, my concern. And so what is my differential for RPGN? Infection, vasculitis, autoimmune, lupus, of course, pulmonary renal syndrome, to me, the top 3 or 4. And when you look at her complements are really on the floor. C4 is 3.1 and C3 are 39. So really hypocomplementemia. You don't have a history of, any type of liver disease or anything like that, but those are really low. And then she has some other autoimmune positivity. She has a little bit of ANA, but she also has the CANCA, which with a little slight increase in PR3, and so then you start thinking of, could this be a vasculitis presenting in as RPGN? How the complements fit in that? And then that gets a little more complicated there. So, then the next thing I look at is her medications. And so the allopurinol and hydralazine, it was mentioned that she's on these, and these are not new medications, right, Chinta? These are old medications.
Yes.
So, that then you say, well, those two are both associated with a drug-induced vasculitis, and you can even have overlap syndrome, especially with hydralazine, where you can have, drug-induced lupus and kind of vasculitic features kind of overlap, and maybe that would explain the complements and some of the autoimmunity, a serological positivity that you're having. So, I looking at all kind of coming in short, and she has MRSA, so infection-related GN, low complements. Maybe the CANCA is a little bit of infection-related. Maybe the PR3 is just, an outlier here, and maybe this is all infection-related GN with, RPGN on top. But it sounds like that grew after she came in. She didn't really present with fever. She really presented with hypertensive, almost emergency there with 220 and evidence of what appears to be, TMA. Otherwise, serologically, Adams TS15 shows 100, so it's not TTP, but again, that wouldn't explain all these complements and proteinuria. Cryoglobulins are pending, so sure, cryo could be a part. Her Hep C was positive in the past, but PCR is negative. Could this be an autoimmune, more cryo? But her complements are low. ANA is not that high. Anti-double-stranded DNA is negative, so it's definitely a consideration. But and so that should be on your differential. And then of course antiphospholipid and antibody syndrome with a TMA, and maybe this is related to that. But ultimately, for me, it comes down to RPGN here, and I think everything for me based on the medications, the low complements, some ANCA positivity goes along with a drug-induced picture, and it could be allopurinol or hydralazine. Both of them have been associated with it. With hydralazine, you typically see a much higher MPO titer. That's the only thing that doesn't fit there, but it could be one of these overlaps where you have just a little bit of positivity. And it's more immune complex mediated based on the complements, and that may be driving more of the active lesions that we may see on the biopsy. I think she will have maybe TMA, but again, I would, instead of having 2 separate processes, maybe it's all related to whatever's going on from drug induced, because that really can't explain her proteinuria. And sure, she could have a complement defect on top of it. Maybe that's why she's more predisposed to a TMA, but I think the TMA could just be from hypertension that she presented with, which may be due to an a GN, and that's why she's hypertensive. So I would say, drug-induced active necrotizing lesion would be number 1 for me. 2 would be an infection-related GN, causing, again, a crescentic GN would be number 2. What else? I mean, membranous, given her age, she has a lot of cancer history. Again, that doesn't fit completely with the serologies, but sure, you could have a crescentic membranous, but then how do you explain the complement? So I think that would put that much lower on my list. Other things, pulmonary renal syndrome, it doesn't seem like that. Chest X-ray was negative, so I think that does not rule it out, but again, anti-GBM was negative. less likely to be a pulmonary renal syndrome from good pastures or anti-GBM disease. What else? I think those are my main. I think COVID was negative, so that kind of takes that out of the picture. So I'm really going towards more of a drug-induced path. I think that would be really what I would focus on here.
So the question kind of comes up about this MRSA, and she did not have fever on admission, but she developed fever shortly thereafter, and that's when they got blood culture. So it's unclear, did she have bacteremia before or not? And there were 2 of 2. Nobody really knows or knew at the time if this is relevant or not, but they were 2 of 2 with Staph aureus, not Staph epi, but
And
it's
I think she'll
unclear
have
if this is something
ATN.
developed. It's something that developed or not in the hospital. I'm sorry.
Yeah, no, sorry. And really, Grant, because she'll have ATN in the background, but I think that's not what's the bigger concern is really the active
Yeah.
sediment with the rising creatinine. I mean, that's the only thing that's hard to ignore with all that serological positivity.
Hey, Bill, how would you put all, and there's a lot of stuff going on here. There's TMA, there's hypertension, there's complements, there's drugs, there's infection, there's low complements, there's things that are pending. What do you think's going on?
I think that this person needs a renal biopsy.
Okay.
I mean, if there was ever a case that needed one, it's this. My goodness. I mean, it reads in the beginning like you're starting to think of a malignancy-related membranous or complication of radiation kind of thing. And then you see her blood pressure is crazy. She's got schistocytes. You're going all down the malignant hypertension TMA route, which, that you want to make sure your ADAM-TS is normal, which it is. So then you see there's low complements. So then my next thought was, oh, maybe it's even an autoimmune, a complement mediated HUS, although obviously you don't have to have low complements in that. You can have alternative pathway activation without having hypocomplementemia. But I was really all in on it just being that. We were going to see thrombi, we're going to see malignant hypertension, we're going to see, and it was going to all be from that. And then we're going to have to figure out if it's malignant hypertension or the what used to be called atypical HUS. But then, my gosh, as if that wasn't complicated enough, we've got all this hypocomplementemia in addition to the hematuria. We've got a staph infection, and then, very immunely active Hep C antibody that's positive and a negative Hep C PCR. We see that classically with lebamisol. The histone's pending, which is either gamesmanship or real, but really makes you think that there is a drug-induced situation sitting here. And just like Pravir said, usually the MPO is markedly positive and not the PR3. So drug-induced vasculitis is in the differential. Regular vasculitis is in the differential. I mean, this is really hard to put a nickel down. I certainly don't have a top 5 or top 10 in this situation, because it could be that it's not parsimonious and we have more than one thing going on. We could easily have TMA from malignant hypertension, as well as a crescentic post-immune GN. So I think the differential was very well discussed by Dr. Baxi, and I don't really have that much to add, except that it could really, I'd be flipping a coin. It's a tough one here.
Yeah, I look at it, when I looked at this case, I said, there's a lot of stuff here. There's the TMA and, et cetera. But the one thing that impressed me the most was the complement.
Complements, yeah. You can't ignore
because,
that.
There's hypocomplementemia and then there's hypocomplementemia.
Yep.
There's C3s of 60 and a C3 of 14, but this is really, C3 of 39 and a C4 of 3.1. That really got to me as a clinician. That to me, if there was one clue to a diagnosis, not that I have a diagnosis or had a diagnosis, I should say, but that's what I put the most weight on. But even with when Dr. Corbett had his case of infectious endocarditis with GN, there was a positive ANCA, and I believe it was a PR3. That the majority of those are PR3 positive. So there's still a lot of stuff out there, and if there's any point that was made from that conference is don't miss endocarditis. So.
And the cryos are still pending. I don't think we have a rheumatoid factor if I had looked closely.
We do not have a rheumatoid factor here. Thank you. Yeah.
So yeah, you're right. I mean, it's you go all in on that, but even if it's such hypocomplementemia, it still could be drug induced. It's really, really hard to narrow it down. I think this is going to be one of the most helpful biopsies we've seen.
Dr. Glassick, you put something in the text. Do you want to discuss it a little bit?
Sure, Roger. I just wanted to raise the possibility of a Staph aureus related IgA dominant infectious GN. The complements are very low, but that can occur in infection-related IgA dominant GN. I think you're all on the right wavelength with crescents. I'm a little worried about the very low serum albumin, which isn't very common in crescentic GN, even with pretty severe disease. I had a couple other things on my list, like collapsing nephropathy, but I don't think that's very likely with the very low complements. And the other thing is, just because the HCV is negative for viral load doesn't mean that this can't be an HCV-related immune complex GN. Because as you know, even with total cure of HCV disease with antivirals, you can still develop glomerulonephritis due to the presence of a monoclonal antibody to IgG. And I didn't see a rheumatoid factor on the list of labs that might have helped.
Yeah, we don't have it here. So yeah, I'm not going to make it up right now, but we don't have it.
Okay.
But yeah, you know, and I think it's a good point, because those hepatitis C related glomerulopathies are often cryoglobulin related, and then if you had a cryoglobulinemia, that could explain the complements, and that might put it together nicely too. And you know, we always think of it as being initially a immune complex disease with Hep C virus, but your point is, you know, absolutely important, that these patients from chronic antigen stimulation often develop a clonal population, and you really end up with a clonal disease and not really a virus so much disease anymore. Let's Pravir, let's put up the poll and see what people do. So I want everybody to vote. Anybody can vote. Just the co-hosts do not end the poll. Don't hit end poll. Well, actually, the only people that aren't co-hosts can vote. So please vote. I want to see what people think. We'll let Pravir end the poll once we get a decent representation.
Shared.
So I think you can all see it. We have, you know, as Bill said, if there was ever a good argument for renal biopsy, it would be this. And I think this is a good example of that we're pretty much all over the board here. Between infection-related GN, we had one ATN, drug-related, only 11%. I thought for sure that would catch on much more. And TMA, I mean, there's a lot of overlap with these diseases. Clearly, you can have, you know, they're not mutually exclusive, but trying to predict the predominant lesion and predominant cause. And the winner right now is infection-related GN, and with a close second is cryoglobulinemia. And that may reflect those are the last two things that were brought up, and that Dr. Glassick is rarely wrong. So maybe if you wouldn't have said anything, the votes would have looked very different. But I think with that, we should get to the pathology and spin the wheel.
Hold on. Wheel. Good time to tell the applicants that you are on the wheel. We're just joking. You're not on the wheel, I promise.
I don't know, Dr. Corbett, are you still on?
I don't know if he was able to do his mouse from his phone.
Oh
I think he's
yeah,
on his
I'm
phone.
here.
You want to
Do
try it
it
from
from your
yours?
phone?
Oh yeah.
Okay.
You want to do it?
Yeah.
Okay.
Okay,
I
Dr.
can control
Corbett.
the mouse if you want. Let's see.
Dr. Corbett
you
is.
have to,
You can.
I think let's do it.
Yep.
Dr.
okay.
Corbett's calling in from Paris, so this will be fun.
no, from Brittany.
Okay.
So we'll give it a shot here. If I don't want to embarrass myself, so if I do, I'll let Roger take over. So can you hear me?
Yes.
Okay, good. So we've got trichrome stain, 3 nice cores actually, very little interstitial fibrosis. In fact, really nothing of significance. And the glomeruli don't look that bad at this power. Is David, David, are you with us here?
Yeah. Yep.
All right,
Yep.
good.
I agree. I
So-
agree with everything you said. Sounds good so
Thank
far.
God. Thank God. Okay, next. Wow. So we've got a PAS, very lobular looking, very lobular looking. And at this power, that's the best I can say is this is definitely an MPGN looking picture. Next. Higher powered PAS, again, extremely lobular looking, mesangium expanded, increased cellularity. At least on my on my view, I can't see a lot. I'm sure there are double contours there. With actually around the capillary walls there, you can see nuclei, which I'm sure is mesangial interposition. And David is, I don't know if that's who's controlling the pointer, but this is definitely an MPGN pattern.
Yeah. The only other thing I'd add is like at 12 o'clock, it even looks a little nodular as well. The mesangium.
Okay,
Yeah. Right there. Yeah.
fair enough. But I mean, a lot of nuclei going around the
Yeah.
capillary walls there. I mean, there's no question that this is mesangial interposition.
Yeah.
Definitely not what I would have expected. I have to admit, when I was looking at this, I was thinking this was going to be some sort of lupus with a thrombotic microangiopathy. An H&E, again, a lot of mesangial expansion with hypercellularity. You know, I don't see any crescents, and there's definitely no necrotic or segmental lesions that I can think. Just a lot of mesangial expansion and hypercellularity. I will defer to David to pick out anything else that might be of significance.
No. I'm with you.
Does it have a bit of a nodular appearance? I mean, we could kind of think about even fibrillary
Yeah.
stuff on
Yeah.
the EM if we.
Yeah. Like 7 o'clock looks a little nodular. Yeah. Right
Yeah.
in there. Yeah.
Fair enough. Okay. Next. Oh, wow. So it's a great silver stain. This is amazing. You know, just looking up at, I mean, first of all, again, it's very lobular. I have a hard time seeing even the capillary lumens, but what I do see is what looks like, David, if you go, I don't know who's got the mouse, but if you go over to like 1 o'clock, there's a lumen. It seems like there's a ton of mesangial interposition with nuclei and cytoplasm going around the
Yeah.
capillary walls there. I mean, it's just, to me, it's just a very MPGN picture.
Mm-hmm. Yep.
Anything, David, anything more?
Yeah. And I agree with that. Yeah. I see a lot of duplication and remodeling of the GBM.
I mean, every one of those, you know, kind of, it's like cauliflower. I mean, every one of those loops has what looks like massive mesangial interposition going around them. And you can see the silver stain in the mesangium itself, but you know, in all honesty, I have a hard time seeing a double contour, but you may be able to point that out.
Yes, and there's also some mesangiolysis as well,
Okay.
like at 1 o'clock.
Okay.
Yeah, above that dark area where it's lighter, some of that is mesangiolysis, and it was better on the PAS stain, which I didn't photograph, but
Okay. So MPGN for sure. And here we have lambda, very strongly positive in the mesangium. Actually, even in the capillary walls, right? Or
Yeah.
I'm sorry, in the tubular basement membranes. Is that true or no?
yeah, especially like we're up around 11 o'clock.
Yeah, I'm actually looking over to like 3 o'clock
Yeah.
in the
Yeah.
tubular basement membranes.
Yeah.
Unbelievably positive there. And as you point out, who's got over the pointer up around whatever that is, 1 o'clock, very strongly positive. So what else do we have on fluorescence? Oh my God. Jesus Christ. Oh man. So this is weird. This is so weird. All right, let's keep going before I give a diagnosis. So I assume IgG and all the heavy chains were negative.
Yeah. So we have monoclonal staining for lambda.
I got that.
Yeah.
So let's keep going. So on the electron microscopy, we're looking here at in the middle is a big mesangial area with a lot of expansion. You see a number of nuclei. I'm sure I have a smaller screen, but it looks like they're electron dense deposits in the mesangium.
Yeah.
Yes, exactly. What I'm curious to see, and I'm sure we'll see it at a higher power, is what the glomerular basement membranes and the tubular basement membranes look like.
Yeah.
But right now, it's deposits in the mesangium and a lot of mesangial expansion and
Yeah.
hypercellularity.
Yeah. So move the arrow a little bit to the left, Pravir, and that capillary wall. No,
Yeah.
the capillary wall at 9 o'clock. Yeah, so you could see a faint outline of the original one, and then those type of deposits on the subendothelial side right there. Yeah.
Okay.
Yeah.
So are they granular? I can't really
Yeah.
appreciate them. Are they
Yeah.
granular?
Yeah.
Like...
We'll see them at higher power. Yeah.
All right. This is too much. So again, higher power, you have two kind of kissing capillary loops, it looks like to me. And in the middle is the urinary space. And you the capillary walls and data are going to have to interpret for me. I mean, this is obviously light chain deposition disease until proven otherwise. Normally, you don't see, we always talk about occasionally you'll see organized tubular deposits, but I don't see them here. But you do see granular deposits along the capillary walls.
Yeah, you're breaking up a bit, but yeah, they're kind of punctate, powdery, electron dense deposits. Yeah, on the inside of the capillary wall.
Kind of all over, right, David? All this.
Yeah. Yep.
Yeah, both sides.
Yeah, so
And the
I
foot
think we lost
process looks
Steve.
pretty at phase 2 here.
We lost Steve. So Pravir, if you could just keep the arrow going. So on the inside of the basement membrane, you can see they're not super dark. On the yeah, there you go. They're not super dark, but they're definitely a whole row of them there, and they're kind of not real discrete. They're what people call powdery,
Yeah.
very fine little particles and kind of powdery, and that's fairly. I wouldn't say pathognomonic, but that's what's described in light chain deposition disease, that they could see those both in the glomerular loop, which we see here. And by the way, there's also, a fair amount of foot process effacement going on in this glomerular capillary wall.
Yeah. So like at 11 o'clock, you could see them underneath the endothelium right there. Yeah. And then also like at 3 to 4 o'clock over there. Yeah.
You can kind of see like a little.
They're electron dense, but they're not super electron dense. But their point is they're not really confluent. They're not like dense deposit or like big lupus membranous or wire loops or anything. And that's why the term is used powdery, kind of sprinkled there.
Yeah.
Next slide.
Yeah, and then these same deposits were present in the tubular basement membranes as well, as we see here.
Mm-hmm. Okay. Next slide. So I know Steve's back, but he dropped for a little bit, but he did make the diagnosis, and he made it really from the immunofluorescence, the fact that there was a light chain restriction lambda that also affects the tubules in a nodular, although quite frankly more of an MPGN kind of light pathology, light microscopy pathology than what we typically think of with light chain. But the diagnosis there is pretty much made by the immunofluorescence, and the EMs completely support that with the powdery deposits. Absolutely complete surprise. It was on no one's radar whatsoever. Dr. Glassick, what are your thoughts about how surprised are you on a scale of 1 to 10?
I would say a 9.
That's pretty good. I'll take that.
So Roger, I have a question.
Yes.
Would this be one of those cases where the light chain behaves as an antibody against complement components, leading to an atypical HUS type picture?
I don't know. That's hard for me to put this all together. I've tried. I'm going to discuss the case a little bit later, and maybe we can come back to some of those thoughts.
Can I also ask, I assume the C3 immunofluorescence was negative?
Yeah, that's a really good point. The only thing that lit up was the
Yeah.
lambda. There was
C3,
no complement.
C3 is negative.
Because in
I
C3
think that's
nephropathy, of course, you can have monoclonal proteins as a cause as well, and there's the hypocomplementemia there too. It shows you the importance of the immunofluorescence in diagnosing the pattern of disease. That MPGN is not a disease; that it's really just a pattern that has all these other causes. And if you only get one stain, you really want the immunofluorescence because that really guides you to the actual answer.
Yeah, that was
Roger?
Yes.
Actually, hypocomplementemia is not uncommon in light chain deposition disease. As Dr. Rubin points out, some light chains have the ability to inhibit the action of factor H on the formation of the C3 convertase and can mimic other causes of activation of the alternate pathway. The problem here is the C4 was very low, which isn't exactly typical of the hypocomplementemic pattern for activation of the alternative pathway.
Yeah. So, I looked that up a little bit. I've got a couple slides on that are probably less valuable than what you just said. But before I give my little talk, Casey, what would you do next?
So I would go down the pathway of working up paraproteinemia and bone marrow biopsy. This is already a monoclonal gammopathy of renal significance. So I think this is going to have to be handed to hematology to find a clone and do a bone marrow and kind of go that route. I'm still puzzled as to how this patient is on dialysis and the creatinine is going up. And that biopsy, to me, there was really not that much ATN. So I'm not sure how to reconcile the two, the biopsy and the clinical presentation of RPGN. But to answer your question, the light chain deposition disease, I would treat as if she has a myeloma type or a clone type renal involvement.
Mm-hmm. And so what do you predict? What do you predict the bone marrow is going to show?
I suspect that she would have at least paraproteins in her bloodstream. I don't know if the marrow is going to meet criteria for actual multiple myeloma, but I would suspect that they will find a clone, a monoclonal. I suspect eventually this will be, whether this is definitely MGRS at this point, but it could actually be full myeloma. I don't know if the marrow is going to meet criteria.
Okay, well, let's give me the next slide and I'll tell you.
I'm assuming the Congo red was negative, otherwise you would have shown it.
Yeah, thanks, Bill. The Congo red is negative.
Yeah, I'll give you control here. Roger, give me a second. Go for it. Yep.
All right, so in follow-up, serum immunofixation did show IgG lambda, monoclonal. Urine immunofixation, interesting enough, found no paraprotein, and the 24-hour light chains were too low to detect. Now, who knows if that's somewhat related to the fact that the patient, when this was done, was in renal failure. But the serum-free light chains was quite remarkably abnormal, with a lambda of 82, a cap of 2, and a ratio of 0.02, extremely low. And there was no question about what was going on because the bone marrow had 90% plasma cells, which were, of course, lambda restricted. The bone survey was done and there were no lytic lesions. So the diagnosis, I guess the hematologists were calling it multiple myeloma. To me, it's a matter of semantics, what criteria you actually use. But it was certainly a plasma cell related problem with very significant plasma cell infiltration of the bone marrow. And subsequently, light chain deposition disease presenting as microangiopathic hemolytic anemia, hypocomplementemia, and as Dr. Gashi said, relatively unexplained AKI. So I'm going to go over some of this.
Can I ask you real quick, Roger?
Yeah.
The proteinuria that you had, it was a 24-hour urine. I think there were 2 grams. Did we ever have an albumin?
It was not, it was about 1100 or something. It was
Okay.
not, yeah, it was, there was not, and that's kind of expected since we didn't really find anything in the urine. It did not have a, a overflow proteinuria kind of picture, if that's what you're getting at. So I just want to go back real quickly. I don't want to spend much time on each of these slides, but Dr. Baxi gave us a very nice differential diagnosis, and you can approach it many ways. One is the patient presents with microangiopathic hemolytic anemia, and there's a whole differential diagnosis of this from TTP, HUS, et cetera. Not many of these really fit her, but if we looked at it, she did have a positive ANCA. Maybe this is an ANCA-associated vasculitis. There was this history of cancer. We've definitely seen crescentic GN associated with cancers, although she didn't seem to have active cancer at the time. She did have malignant hypertension, but who knows if that's primary or secondary to what's going on. And she was on some drugs that could be related, but nothing was really helping us very significantly. And, once we ruled out TTP, we're kind of left with kind of everything else. So nothing helped us quite there. You could approach it as a hypocomplementemic GN because it was profound hypocomplementemia. And the differential diagnosis is not limited to this, but it's often infection-related GN. And Dr. Glassick brought up the staph-related IgA. Even though post-streptococcal glomerulonephritis very commonly has a low C3, the relationship in IgA, Staph aureus-related IgA isn't quite as high, and the ones I've seen haven't been quite as low. But definitely, that's in the picture. There's also shunt nephritis, which is infected ventricular peritoneal shunt or ventricular blood shunt, endocarditis, et cetera. There's MPGN, which is kind of almost shouldn't put that up as a term anymore. Lupus nephritis, cryoglobulinemia, C3GN. But, again, nothing was, I was thinking cryoglobulins. By the way, cryoglobulins were negative, of course. Antihistamine antibodies were negative, and antiphospholipid antibodies were negative. We got those afterwards. Of course, the biggest test we got after the biopsy was the paraproteinemia workup, which we had no intention of doing beforehand because it really didn't fit our clinical suggestion. And there's other ways to look at hypocomplementemic GN, and that, was also brought up, whether it's kind of the alternate pathway, which is low C3 alone, or the classical pathway where it's both C3 and C4. And given they were both C3 and C4, these are the infection ones that, are a little less likely and more likely to be more of an immune complex like lupus or cryoglobulinemia. And I was really thinking one of the best ways to put this together would be a cryoglobulinemia, but of course that wasn't it either. And then we've got this, hydralazine just screaming at us, this story, and allopurinol, and I really like that because it could put everything together. It could put a GN together with all the serology, a little bit of this, one from column A, one from column B. We've got low complements. We've got an ANCA antibody, and but it didn't turn out to be that either. And then finally, there's just the approach that was brought up is this just RPGN, but RPGN is a clinical diagnosis, and crescentic GN is a pathologic diagnosis, and they're not mutually exclusive. They often go together, but they don't have to go together. But almost anything has been associated with crescents, even amyloid and membranous, and as opposed to some of the more obvious ones that we see. And it didn't really fit that either. So what was missing in all of these three approaches, whether it's TMA, hypocomplementemia, or systemic disease, RPGN, what's missing is our diagnosis, and our diagnosis was a paraproteinemia. And just get back to Bill's point, which is why sometimes we just have to find out what's going on. And I don't know if we would have come up with the diagnosis without the biopsy. I don't think that was something. So this is what was alluded to by both Dr. Rubin and Dr. Glassick, as trying to put this all together somehow. So the good thing about Google is you can find anything you want. The bad thing about Google is you can find anything you want, and people that report things, there's always reporting bias. Having said that, I mean, I put in TMA with multiple myeloma, and there was no shortage of reports that came up, but it's not something that I would normally think of. If I see a TMA, I'm not automatically looking for a paraproteinemia. Maybe I will now, but that was not part of, I don't think that was even on my list, that long list of TMA entities that I showed earlier. And the other factor was this hypocomplementemia, and I'd like to hear a little bit more about this, because that's something I did look at, and I tried to find anything on light chains. I couldn't find on it, but there are, IgG1 and IgG3 will fix complement, And you can have hypocomplementemia, but if you look here at the C3s here, they're not in the 40 range. Or the C3s here, they're not in the 40 range, and the C3s are just not that low. So, I don't have the experience to say one way or the other, but, I think getting back to Dr. Rubin's point is that, do you think this is somehow related to that? I mean, I think he has to be right. I think that the TMA and they're all related to the paraprotein somehow, but I can't really completely put that together, that pathophysiologically how that happens, other than it's been described. So, Mario, did you want to elaborate on that again?
Yeah, it's basically what Dr. Glassock alluded to, and there are two reports, one from the Mayo, and Fervence is one of the authors. The other comes from France. Dr. Glassock remembers the name, I'm sure, of the scientist there. I don't. But basically, they mention the fact that the monoclonal protein behaves as an autoantibody against factor H, and thus the cascade of the C3 convertase is enhanced of the alternate pathway, and that allegedly is the theory. And if you believe that that is the mechanism, then pheresis would be part of the treatment that you should employ.
And just like you said earlier, that can also go down the pathway of TMA.
Right.
Pretty amazing. We could get factor H levels. I know that they take a while, but we can measure the complement system. Were you able to get blood sent off for that, Roger, or probably not?
No.
Okay.
And Nelson Long, in his review on MGRS, explains this mechanism. So that's another interesting paper to read.
Yeah, so as I said, the good thing about Google is you can find everything. And so the funny part about it now is that I did try Googling it and I didn't find that. So I really do appreciate that information, because it does put it all together in a much better form. Let me talk a little bit about, yeah.
There's a cool little trick that was done in the JCI paper that originally described the effect of light chains on complement. And that is to take a normal serum and mix it 1-to-1 with the patient's serum, and then remeasure the complement. And if the complement doesn't go up, that is an indication that there is a substance in the serum that causes complement conversion. You don't need to have a factor H level. This can be done in any lab that can measure complement. That is C3. That was present in the paper in the JCI, the 1-to-1 mixing phenomenon.
Mm-hmm.
And I don't think it's ever been systematically looked at, but I think it's worthy of mention.
Yeah, I appreciate that. And we'll try to get some references out after the conference. So let me just review this topic a little bit. The best review I found on light chain deposition disease is a subset of MIDD, which includes light chain deposition disease, light heavy chain deposition disease, and light and heavy chain deposition disease. It was put out of the Mayo Clinic. And I invited Dr. Nelson Lung to join us today, and he would have loved to. Unfortunately, he is taking his boards today, of all things. So I'll get him back for another case, but I would have loved to have him on because, I doubt many people would know more about this than him, and certainly as an author of this paper, probably the biggest series. They had 64 patients, but the majority of them had light chain deposition disease, 51. The mean age is 56, but 36% were less than 50. So it is a younger population than your typical myeloma cast nephropathy or an AL amyloid, which is pretty interesting. The serum M spike in 73%. So not all of them you can find in the blood. Sometimes it becomes a monoclonal gammopathy of renal significance, and you have to go searching. You're not sure until you do the bone marrow and find a clone, or sometimes you don't always find a clone. But what's interesting is serum-free light chains were abnormal at 100%. Thank God we have this test, because it certainly has improved our sensitivity of picking up monoclonal paraproteins. They present with renal insufficiency, proteinuria, hematuria, hypertension. Nodular glomerular sclerosis, interesting, was only present in 61%. That's our classic lesion. This was kind of a mixed nodular, mixed MPGN-like picture. And it does have a high recurrence rate in 3 or 4 transplanted, assuming it's not cured. Here is some of the demographics of these patients. As you can see, the average age is 55. Large proportion of them were white. I don't know if that's significant or not. Average creatinine at presentation was 3.8. I'm just looking at the light chain deposition disease. And a number of them were dialysis dependent at biopsy, which is what was the case here. 24-hour urine protein at 3 grams, nephrotic range, not a lot, and that kind of fits our picture too, that it's a little bit different than, say, than AL amyloid. And the albumins really aren't that low either. And microscopic hematuria in 60%, which kind of fits our case too. Next slide. Or I can advance, I think. So this is, again, what it looked like, that 61% had this nodule. This is a little more typical with the textbook. Ours was more MPGN-ish, where this, has clear nodules with a lot of amorphous material in the mesangium. But 31% did not have any nodule, and this would be a much harder diagnosis to make. I mean, obviously you'd get it, you'd get it on immunofluorescence, but, and I don't think we had a strong suspicion. I was certainly along the lines of an MPGN which is what Dr. Corbett was until the immunofluorescence comes up. And this is fairly typical. It's more often kappa than lambda, and ours was lambda, but this would be a typical picture in the glomerulus. But very importantly, the tubular basement membranes of the will light up as well with the monoclonal light chain, and it should be light chain restricted. Ours was lambda, and this is kappa, but this is fairly typical. And another picture with this is a really nice I got from the internet, because it just shows the really nice nodular pattern which is described, and then also showing up in the tubules as well. And this is a little bit better look at the powdery deposits. Here you can see them. I'll show you a high power. Here's in the GBM, and you can see them in the tubular basement membrane as well. But here's a really nice picture where it shows how non-discrete they are. And it really does look powdery. And that's where the term, that description came up, which is what's most described. But again, the diagnosis is immunofluorescent diagnosis, but it's nicely supported by the EMs here. This just kind of shows the degree of, interstitial fibrosis when they were found, the number of glomeruli, the amount of nodular was only 60%, as I mentioned. Interestingly enough, heavy chain had a higher percentage of nodular, but this was not a large N. Monoclonal proteins were found, but, in the majority of patients, it was kappa, not lambda. Mesangial deposits were seen, but certainly tubular basement membrane and glomerular basement membrane were by far the highest amount here, in the 90 to 100%, where mesangial only about 65%. I think we saw pretty much all of the above. And looking at the, what was actually found, multiple myeloma with as they're defining here, is greater than 10% plasma cells, was in 2/3 of the patients. And our patient clearly had myeloma, but also with 90% plasma cells. But we also did not have lytic lesions, which they rarely had here, and very rarely hypercalcemic. So it kind of reacts differently than your average myeloma that's kind of destructive, and lytic lesions with hypercalcemia. Again, mostly kappa. So here is the positive urine and serum immunofixation, not 100% by far, but abnormal free light chain ratio. Again, what a great test this is. In this series, 100% of them were able to show in a very abnormal, either it would be high if it were kappa or very low if it were lambda restricted. And how did they do? Well, it was over a number of years. So, the stem cell transplantation wasn't always available during this study, but, most of them did get chemotherapy. About a third of them got a stem cell transplant, but even of the 14, about 6 ended up on dialysis anyway. But a lot of these patients improved, 60% of them improved in having received therapy. And it'll be interesting to see what happens to our patient, whether or not she will improve. 30% did die, and who knows? I don't have the exact data on eras for that, and I would be surprised if, because the follow-up was only a couple of years. I think the mean follow-up here, mean was about 3 years, 35 months. So I think patients would do better now. This probably reflects some of the older therapies, perhaps even before proteasome inhibitors. So what happened? Well, she got diagnosed as multiple myeloma, got Cyborg D, and she's out on dialysis, and she's now being followed by our hematologist oncologist. And she did start making a little bit of urine on discharge, which gets back to Dr. Gashti's question about the acute renal failure. And I don't know if we can go back, Pravir, to the first pathology slide.
Yeah, we can. Hold
But
on.
if you can't remember, I mean, I think Dr. Corbett said it from France from his little iPhone. There was very little to
Yeah, I'd like to just put it up there. Yeah, I think that's really important.
The trichrome was basically no blue. It was great.
Right here. So it should be visible.
So I'm putting you through this for a reason, but I think it's worth looking at. Is that, yeah, I mean, that's not an end-stage kidney, and I don't care how much ATN we saw. And there's not cast nephropathy, which always pointed out in the chat, that there must be a very large element of AKI from something. Maybe it was her staph infection. Maybe there was an element of something else. But I do not see a dead kidney here, and I think there's a really, really good chance that she'll get better and come off dialysis. But only time will tell. I'd like to open it up for anybody else's comments.
Roger, I know you like history, and it's interesting to remember what Dr. Gashti said, that this was myeloma, because when Robert Kyle wrote the initial descriptions of multiple myeloma, he said that 75% of them had a positive spike in the serum, 24% of them had it in the urine only. And then he ascribed 1% to non-secretory myeloma, which then when the free light chain assay became available, the non-secretory went away. Certainly the Mayo did the key study on the role of pheresis in light chain myeloma, and was a negative study, although we hear from time to time about high cutoff dialysis as being used for that purpose. But this case of yours is different. This case has TMA. And the cases at Mayo that failed pheresis, to my knowledge, did not. So I wonder what happened to the TMA once the patient began chemo.
Well, she got chemo, so I'd have to go back and see exactly if her platelets came up or went down. I mean, they very well could have gone completely down. And I off the top of my head, I don't remember. And I thought about that earlier. I probably should have had a little more hematologic follow-up. But remember, there was no TMA on the biopsy. And I asked David to specifically look for that. So she had microangiopathic hemolytic anemia, but I don't know that we can say she had a TMA histologically because we didn't see it. But, maybe there was. As far as pheresing her, I didn't really, there was not a high light chain load. I mean, I'm not sure what I would have been removing. It was very, very low concentration, even in the blood, and nothing in the urine. So it wouldn't have been wrong to do, but at that point she was going to get chemo, and I didn't want to take any chance of like pulling off the chemo with our treatment. It all happened very quickly. And I didn't want to, I wanted her to get her chemo in and not risk losing any of the drug down the drain. So we just went ahead with that. And I think her prognosis is pretty good. I mean, I think that there's a decent chance that she'll open up, but only time will tell. I've seen, these myeloma patients take but at least that's with cast nephropathy, open up 2 or 3 months later. And I think if that's going to happen here, this is more of an ATN, this may be faster, but like I said, only time will tell.
Well, it's interesting. Dr. Shah points out that her platelets went up to 271,000 upon discharge. So probably the TMA resolved with the chemo, which is what Dr. Reen suggested.
Yeah, I'd love to see her compliments too. I would agree that they're probably normal, and all that stuff kind of went away. And this is not a manufactured story. This is what she exactly presented with, and talk about being shocked. But we do what we do, and we do it for a reason. And fortunately, we came to a diagnosis. And fortunately, we've got a pretty good treatment for this, and we'll see how she does. And I suspect she's of an age that she could, still get a stem cell transplant and do pretty well. All these diseases used to be a death sentence, and then, the proteasome inhibitors came out and it changed everything. And now stem cell transplants come out and it changed everything to another degree. And there's long-term survivors to the point where now we're talking about even doing renal transplants on people with primary amyloid, which, you know, would have been absurd in the past. So I think, you know, it's an exciting time for paraproteinemias, and not only hematologically, but for nephrology, because of all these new monoclonal gammopathies. And imagine how many different patterns of injury a monoclonal protein can do in the kidney. It's just absolutely incredible, from, you know, Congo red positivity to proliferative GN with monoclonal deposits, to nodular glomerular sclerosis, to cast nephropathy, to crystals, to crystalline tubular disease, to crystal globulinemia. It really is amazing. And hopefully we'll be able to figure this out more in the future, but I hope we never stop doing biopsies, because it sure is a fun case. So I want to wrap this up. Thanks, everybody. Thanks for being here today and hanging with us. This was a fun case to discuss, and very humbling from a clinician standpoint, because here we think we know everything, and we leave it up to our pathologist to give us the diagnosis, and then that leads us back to the diagnosis. So we'll be back next week. Until then, everybody stay safe, and thanks a lot.